Okay, let's go ahead and get started now. We're going to take a look at the muscles of the human body. And there's a list of those found in the lab guide. And I'll go ahead and send you another list also to make sure that you know exactly what we're looking at. So let me start this and get us right into muscles for lab. So everybody should see the screen. And there we go. Okay. So in the study guide for AP1 Lab, which is in the beginning of the content section, where you have the list of bones, for example, there'll be another section there that has a list of the muscles. There's only about 60 muscles altogether, so that makes it a whole lot easier to to learn. Now, the first question we have to look at, though, is how do muscles attach to bones? And there's a couple terms here. The origin is the attachment of a muscle to a bone that doesn't move. So there's an origin, and there is an insertion, and there's an action. The origin is attachment to a bone that doesn't move. For example, we talked about the deltoid tuberosity on the humerus. That's where the deltoid muscle inserts on the humerus. Its origin is on the scapula, and it doesn't. It doesn't. The scapula doesn't move. Scapula hardly ever moves. It doesn't get to do a whole lot of moving. But the origin of the deltoid muscle is on the shoulder, on the scapula. It inserts on the humerus. The humerus moves. So the origin of the muscle is the scapula. The insertion is the humerus, and its action is to move the humerus. And so we see that muscles are always going to have at least 2 points of attachment, sometimes 3. Sometimes you'll see a muscle that has several origins. It usually only has one insertion, but it will have several origins. And the movement is when the movement occurs, when the muscle moves a bone that's attached to it. It moves the bone that it inserts on. It pulls on that bone. And so we say the bone that doesn't move is the origin, the bone that moves is the insertion. Now, here's an example of an origin and an insertion. This particular muscle, there's a pair of muscles here, and their origin is sort of counterintuitive. The origin here is going to be on the clavicle and on the sternum. So their origin is down here, because the clavicle and the sternum don't move very much, if at all. So we have the sternum and the clavicle. The insertion is going to be on the mastoid process. Now, this particular muscle allows us to turn our head left and right. By pulling on the mastoid process on one side or the other, our head can turn to the left or to the right. So the mastoid process moves, but the origin doesn't. The sternum and the clavicle don't move, but the mastoid process does. And our action is turning our head left, turning our head right. And if they both muscles contract, then we move up and down. Now, muscles only move by contracting. They contract and then they relax. They contract and they relax. The only action that the muscle can do is contract, and then it relaxes. Now, so this, let me go back one here. So this is an example of an origin and an insertion. Very straightforward. There's only a handful of muscles and bones that we pay close attention to on the origin and the insertion of. So we have definitely improved this exam and this study of muscles over the years. I don't want to go there. So, okay, now, so we'll start here with the arm muscle, the muscles of the arm. This is an arm. It is a model. These models are going to be on a cart. If you are in the Sevierville area, you can come on campus, and the muscles will be on a cart in rooms 217 at Maples Marshall Hall. Again, all you have to do is ask campus police to unlock it for you, and they'll be more than happy to help you. But here we see a typical arm muscle. And you can see the first muscle we see is called the brachial muscle. Now, the brachial muscle sits right between two muscles that we probably know really well: the biceps brachii and the triceps brachii. The biceps and the triceps. In between are in between of the triceps and the biceps on the arm, we find the brachial muscle. Above the brachial muscle, almost in a straight line with the brachial muscle, is the end of the deltoid muscle. This is the deltoid. This is the portion here that's going to go down and insert on the deltoid tuberosity on the humerus. So we have the brachial muscle right in the middle, the biceps brachii on the superior surface and the triceps brachii on the inferior surface. Now, I'll give you a hint here. If it says biceps, bi means two. This thing has two, the biceps brachii has two heads. The triceps has three heads. So it has three, the biceps has two origins. The triceps has three origins. Another muscle that we see on the arm starts in the upper arm and ends in the lower arm. This is called the brachioradialis. This is the muscle that allows our radius to do what it does, to turn. It allows the radius to rotate. The head of the radius rotates around the capitulum. And by doing so, the brachioradialis muscle this is what we use to turn a doorknob, turn a key, if we don't have push start in our cars. It allows you to turn a screwdriver. This kind of rotating action using the radius to turn is from the brachioradialis. There's the brachioradialis. Its origin is on the humerus, and it inserts at the distal end of the radius, and it causes the radius to rotate. Turning a doorknob, turning a key, turning a screwdriver, rotating the head of the radius around the capitulum. Now, let's take a look at these muscles a little slower now. Okay. So first of all, this is one we're all familiar with. This is the deltoid muscle. This is the big muscle of our shoulder that we usually get injections in. If you had an injection recently, more than likely it was placed into the deltoid muscle. Occasionally we get them in our gluteus medius. If it's like an antibiotic or a steroid, we usually get them there, but most other injections are going to be like vaccines and stuff like that are going to be in the deltoid. On the superior surface of the arm, we have the biceps brachii. We have, and on its counterpart, on the inferior surface, is the triceps brachii. Biceps on top, triceps on the bottom. This muscle here is sort of an unusual muscle. It is called the Teres Major. And every time you have another hint here is if you have a word like major, you're going to have minor. You have superior, you're going to have inferior. If you have posterior, you're going to have anterior. So if you have a teres major, you're likely going to have a teres minor. And you also have the brachioradialis. Now, the brachioradialis is also characterized by these three nerves that come down across here. As the brachioradialis rotates around, curves around from the humerus down to the end of the radius. And it's characterized by these three large nerves right here. And again, this is the muscle that allows us to turn things around, open doors, for example, to turn keys, to turn screwdrivers. And then, of course, we have the brachial muscle. The brachialis in between the biceps and the triceps. So the biceps brachii, we'll take a look at this one first in greater detail. The biceps brachii allows us to flex our arm. If you hold your arm straight out and make a fist while your arm is straight out, and then bring the fist back to touch your shoulder. That's flexing the arm at the elbow. That's called flexing. So you have your arm straight out, you make a fist and bring it back and touch your shoulder with your fist. That's flexing the arm. You're bending the arm at the elbow. The reason that you can do that is that the biceps brachii, which is attached to your scapula, is also inserted on the radial tuberosity. because there's the radial tuberosity right there. There's the insertion of the biceps brachii. Its origin is on the scapula. And so when the biceps brachii contracts, it pulls your forearm towards your shoulder. So you hold your arm straight out with your palm up, and then make a fist, still palm up. Bring the fist up and touch your shoulder. That's flexing the arm. You're pulling the biceps brachii, the biceps muscle is pulling on the radial tuberosity, pulling your arm up. You're flexing it. You are flexing that arm. Now, how do you get it back down? How do you, what enables you to stick it straight back out? Well, that's called extension. Triceps brachii is involved with extension. The triceps brachii has its origin on the scapula, and it inserts on the olecranon process. And the olecranon process, when you pull on the elbow, the olecranon process, when you pull on the olecranon elbow, so take your arm, stick it straight out, flex it, bring your fist back to your shoulder, and now you want to get it, you can't go around all day like this with your arm bent at the elbow. So your triceps muscle on the inferior surface of your arm will pull on the olecranon process, pull on your elbow, and pull the arm out. That's called extension. So the biceps brachii flexes your arm, the triceps brachii extends your arm. So you can bend your arm back and forth using those two muscles. So we flex the elbow joint, or we extend the elbow joint. We flex it, we bring it, we decrease the angle. Extension, we extend the angle. So you see flexing by pulling on the radial tuberosity, extension by pulling on we pull on the olecranon process and straighten the arm back out. And here we can see what's happening with the biceps and the triceps. You can see there's the biceps on the superior surface. It's pulling on the radial tuberosity to cause flexing to straighten it out. We have the triceps on the inferior surface, and the triceps inserts on the olecranon process, and that extends the arm and increases the angle. Now the deltoid muscle sits on top of the shoulder. It inserts on the deltoid tuberosity of the humerus. And when the deltoid muscle contracts, it allows us to bring our arm in close to our body. That's called adduction. We add, we adduct the arm. We add the arm closer to the body. So, so the insertion of the, excuse me, the insertion of the deltoid muscle is on the deltoid tuberosity. There's the deltoid muscle, moving the arm. But you can see its insertion is right here on the deltoid tuberosity. Now behind the deltoid, we have a series of 4 muscles. Some of the names of the muscles are going to be very familiar to you because of the same names as the bones they sit on top of. So first of all, we have what's known as the supraspinatus. Supraspinatus sits in the supraspinous fossa. It is one of the 4 rotator cuff muscles. We also have, it's called the supraspinatus because it's above the spine. It also sits in the supraspinous fossa. Below that, we have the infraspinatus, which sits below the spine in the infraspinous fossa. So this is the second of the 4 rotator cuff muscles. The third muscle in the rotator cuff mix is what we call the Teres Minor. It also is found below the spine, but it's tucked underneath the infraspinatus. Supraspinatus, infraspinatus, and teres minor. Teres minor is the only one we haven't, that doesn't relate to any structure that we've seen before in bone. So we have the teres minor, supraspinatus, infraspinatus, and the teres minor. This fourth muscle here is the teres major, and the teres major is not part of the rotator cuff. Teres major is not part of the rotator cuff. But if we have a minor, we've got to have a major. If we have a major, we've got to have a minor. The rotator cuff muscles are all unique. They all insert on the head of the humerus. All four of them. We only see three of them here. The fourth one is on the other side of the scapula. So we have the supraspinatus in the supraspinous fossa, the infraspinatus in the infraspinous fossa, the teres minor tucked underneath the infraspinatus. The teres major is not one of the rotator cuff muscles. Neither is the deltoid. There's the deltoid right there. Now, the rotator cuff, four muscles involved in pulling on that all insert on the head of the humerus. They allow the humerus to have its extreme range of motion. They form, the four muscles come together and form a cuff on the head of the humerus, allowing it to be pulled in different directions so that we can rotate our arm almost in a full 360 degrees. It gives us this tremendous flexibility. It holds the humerus in the glenoid cavity, because remember, the glenoid cavity is not much of a cavity. So we have the supraspinatus, the infraspinatus, the teres minor, and the one we haven't seen yet, the subscapularis. It's found on the subscapular fossa. This shows you the subscapularis underneath. This is the muscle in the subscapular fossa on the underside of the scapula. This is the fourth of the rotator cuff muscles. Of course, there is the biceps and the triceps. Couldn't resist pointing those out too. Okay, now here we're looking at, again, the anterior, excuse me, the anterior surface of the rotator cuff muscles. There's the spine of the scapula. Here is the supraspinatus muscle. Here is the infraspinatus muscle. There is the teres minor right there. And I left off the teres major because it's not one of them. So, this teres major up there is not one of the rotator cuffs. So the next one is the subscapularis. So here we see supraspinatus, infraspinatus, infraspinatus, and teres minor right here. And then there's the teres major and the triceps. So now only the supraspinatus, the teres minor, and the infraspinatus are three of the four. Here is the subscapularis. There's the fourth one on the underside of the scapula. So the four muscles, supraspinatus, infraspinatus, teres minor, and subscapularis. These are the easiest to remember what they do. They all originate on the scapula. They all insert on the head of the humerus. They all allow the humerus to rotate around the shoulder. For example, here we see three of the four rotator cuff muscles. Their origin for the supraspinatus is up here on the supraspinous fossa. The origin of the teres minor and the infraspinatus are also here in the infraspinous fossa. They all insert on the head of the humerus. There's the head of the humerus right there. The only one you can't see is the subscapularis, found on the other side of the scapula. We'll see that here in a second. Now, this is how they work. Here we see the subscapularis. Here we see the infraspinatus and the teres minor. When the teres minor and infraspinatus contract, the head of the humerus rotates backwards. When the subscapularis contracts, the head of the humerus rotates forward. When the supraspinatus contracts, the humerus is elevated. So the fourth one is going to insert right here. There it is. There's the supraspinatus right there. When it contracts, it pulls the humerus upward, rotating it outward, rotating the arm outward. So you have 4 different muscles all pulling on the humerus at the same time, depending on what we want to do. And it gives us this extreme range of motion. So we see the supraspinatus acting there. You see, again, there's the supraspinatus pulling on the head of the humerus, and so is the subscapularis. We don't see that because it's on the other side, but the arm is now rotating around. Of course, now there's the teres minor pulling on the head of the humerus, allowing it to rotate laterally away from the midline. There's the infraspinatus rotating the arm. We don't need to remember what the specific actions are. All you need to remember is that the 4 muscles of the rotator cuff, you have to remember what they are, but they all originate on the scapula. They all insert on the head of the humerus, and they allow the humerus to have its extreme range of motion. So these called the rotator cuff muscles because they form a cuff that the head of the humerus sort of sits in as they attach to it, holding it in the glenoid cavity and allowing the arm to rotate again freely around that joint. So, of course, there's what the action of the subscapularis does. You can see that these 4 sets of muscles are going to pull in 4 different directions. And when they combine their motion, you have almost an unlimited range of motion here at the shoulder. So, and of course, again, pulling backwards, pulling forward. Rotator cuff injuries occur frequently. There's 2 age ranges. Young adults, particularly play in various types of contact sports, sometimes non-contact sports, or sports that shouldn't be contact but become contact. And older people, the elderly. We have injuries from wear and tear from contact sports and various activities when we're young, and we have wear and tear and wearing out of these muscles at their tendons and ligaments as we age. Mostly what happens is we see tears in the tendons, tears or inflammation in the tendons. Rotator cuff repair is a very common surgery among older people because they lose that flexibility in at their shoulder. And so it's a fairly easy repair to go in and repair the torn tendon. And it works. I've known many older people that have had rotator cuff surgery and have terrific range of motion again, thanks to that surgery. But you can expect to see rotator cuff injuries in athletes, in the young adult or adult age range, and then you can see them again in the older adult from a lot of wear and tear over life activities. So, and it's very painful. It limits the flexibility of the arm. Here's a supraspinatus that's torn. It's really the ligaments that are torn, and it extremely limits the range of motion. It causes a great deal of pain to move the arm at the shoulder. So what do you need to remember from the arm? Well, you need to remember that the biceps inserts at the radial tuberosity and flexes the arm, and the tricep inserts on the olecranon process and flexes the arm. And you need to know the muscles of the rotator cuff and their origin and insertion. So you need to know the names of all the muscles we've just talked about. I'm only going to ask you a few of them, what their range, where their origin and insertion is. Don't expect, just because I mentioned it doesn't mean that you have to know it. I will emphasize, like, know the origin and insertion of the rotator cuff muscles, and their action is to move the humerus. The origin of the insertion of the biceps is on the radial tuberosity. The insertion of the triceps is on the olecranon process. The biceps causes the arm to flex at the elbow. The tricep causes it to extend at the elbow. Let's look at the leg. So we're looking at the leg. First, we'll pick on some of the lower leg muscles. Here we see the tibialis anterior. Now, the tibialis anterior runs right alongside the anterior crest of the tibia. If you remember, the anterior crest is that sharp edge of the tibia. The muscle that runs right beside that is the tibialis anterior, adjacent to the anterior crest. Adjacent to the tibialis anterior is the extensor digitorum longus. And usually if you have a longus, you're going to have a brevis or a brevis, to indicate short. Now, the digitorum longus, you don't need to remember what it does. I'll just tell you what it is. It allows us to spread our toes out, to splay out our toes. Because when we walk, we're not aware of it, but when we walk, our toes spread out. Our toes spread out to give us a better grip on the surface that we're stepping on. And we don't see it if we're wearing shoes or sandals or something like that. But if we walk barefoot, we can see that our toes would actually be spreading out to help stabilize our position. And it's these muscles, the extensor digitorum longus, that allows that to happen. It's also the one that has a bolt stuck in the middle of it too. Not really, but on the model it does. Okay. On the posterior portion of our leg, we have two sets of muscles, one tucked on top of the other. This is called the soleus, and it sits on top of the calf muscle, also known as the gastrocnemius. It's that big, thick muscle you can feel on the back of your lower leg. That's the gastrocnemius. More on that later. Now, moving backwards from the extensor digitorum longus, we have the peroneus longus, and we have the peroneus brevis. And these muscles, again, also help to stabilize our foot when we step. They, again, help control the movement of the toes. But I'm not worried about the actions in here. There's a lot of muscles to name. So, tibialis anterior, right next to the anterior crest of the tibia. Adjacent to the tibialis anterior is the extensor digitorum longus. The soleus muscle is on top of the gastrocnemius. The gastrocnemius is our very large calf muscle. And then we have the peroneus longus in between the soleus and the extensor digitorum longus. And this little yellow structure here is the peroneus brevis. Okay, let's take a look at some more of these muscles now. There is the gluteus maximus. The what some people refer to as the butt muscle. And that's, that's one of the reasons why I no longer, even if you were taking this test on the ground, you would have a word bank to use, because I don't, I had too many people write in other terms for gluteus maximus. So it was easier to use a word bank. And plus I don't, if I use a word bank, I never take off for spelling, but some people did. I don't like to do that. But with a word bank, you never have to worry about the spelling either, or translating it. Anyway, gluteus maximus. The muscle in the front of the gluteus maximus is called the tensor fasciolate. It's a large muscle. It runs all the way down past the knee itself. There's our extensor digitorum longus right there. There is our peroneus longus and our peroneus brevis. We have the tibialis anterior. Again, there's the soleus muscle. Okay, comments on the gluteus maximus. Very large muscle at the top of each leg. It is not the site of injections. We do not inject in the gluteus maximus because directly underneath the gluteus maximus is the greater sciatic notch and the sciatic nerve. Sciatic nerve at that point is about the size of your finger. It's easy to find and hit. We tend to inject in gluteus medius, which is over here when you find the iliac crest and come down about 2 fingers width, you find the gluteus medius. And this is where most of us get our injections. When you get an injection in the hip, you're not getting it here. You're usually getting it up and to the side. Because we want to definitely avoid hitting the sciatic nerve, because that is a new experience in pain for your patient that they don't need to enjoy. Now, the tibialis anterior, remember I said how the extensor digitorum longus helps to spread out the toes? Tibialis anterior causes us to invert our foot. Dorsiflexion means we raise our toes. When we walk heel down, toes down. Heel up, toes up. Heel down, toes down. Heel up, toes up. Dorsiflexion is raising the toes. Plantar flexion is raising the heel. The tibialis anterior allows us to dorsiflex our toes, bring our toes up, point our foot upward. Because our walking process, it's a heel toe. We're not aware of it. We don't pay attention to it. If you start watching how you walk while you're walking, you'll probably fall down. Definitely don't try it on the stairs, because you will fall down. But the tibialis anterior is the muscle that raises the front of the foot. The Achilles tendon, which we're going to see here shortly, raises the heel and lowers the front of the foot. So the heel, when the toes go up, the heel goes down. When the heel goes up, the toes go down. So the tibialis anterior is going to raise the toes for us. That is its action. Dorsiflexes and inverts the foot. Okay. So that's the tibialis anterior is probably the most important muscle in the front of the leg, because this allows us, and this is half the process of walking. We have to walk. We have to raise the toes, then we have to raise the heel. So in the front of the leg, it is the tibialis anterior that does it. Now, yes, the extensor digitorum longus and the peroneus longus and brevis, they let you spread out the toes and they stabilize your position, but none of that would matter if you couldn't raise your toes. None of that also matters if you can't raise your heel. So walking is a process of raising the heel, raising the toe, raising the heel, raising the toe. We don't pay attention to it, but that's what we do. Okay. In the foreleg, in the upper leg, in the thigh, we have 3 muscles that share the same last name, or I'm sorry, the same first name. Vastus. We have the vastus medialis. We have the vastus lateralis. We have the vastus intermedius. You don't see the vastus intermedius. It's hidden underneath this rectus femoris. But we have vastus medialis. It is on the medial side of the thigh in the front. It is lined up with the big toe. The big toe on these leg models is always on, well, the big toe is always on the medial side. So the vastus medialis is on the medial side of your thigh. The vastus lateralis is on the lateral side of your thigh. And underneath the rectus femoris is the vastus intermedius. These are called the quadricep muscles. This is 3 of the 4 quadriceps. We call them the quads. We have vastus medialis, this is the big toe side. Big toe is down here, vastus medialis, vastus lateralis. In the middle is vastus intermedius. And then we have the rectus femoris. So these are the quads. Their counterpart, their antagonist, and I haven't mentioned this yet, but I need to say it now. Muscles work in antagonistic groups or pairs. Muscles have antagonistic pairing. One set of muscles does one thing, a counterpart does the other. The biceps is the antagonist to the triceps. The biceps flexes the arm, the triceps extends the arm. They have an antagonistic pairing. They work opposite of each other. The quads are going to work the opposite of the hamstrings, the muscles in the back of the thigh. So these 4 quadricep muscles are going to be the antagonistic pair. They're going to be half the they're going to be the antagonist to the hamstrings. So quadriceps, there's 4 of them in the thigh, in the front of the thigh. The vastus medialis, the vastus intermedius, the vastus lateralis, and on top of the intermedius, we have the rectus femoris. I don't know why they named that. Okay. There's the rectus femoris right there. It is one of the 4 quadricep muscles. What the quadricep muscles do is to flex the thigh and extend the lower leg. Now remember that when we flex the arm at the elbow, we narrow the angle. So if we're flexing the thigh, we're going to bend the thigh back and narrow the angle at the knee. Flexing is flexing is bringing your fist to your shoulder. That's flexing the arm at the elbow. Extending is straightening out the ankle. So the quadricep muscles flex the thigh and extend the lower leg. Remember that now. The hamstrings are 3 muscles on the posterior surface of the leg directly below the gluteus maximus. We have the biceps femoris, and we have the semitendinosus and the semimembranosus. Now, the semitendinosus is on top of the semimembranosus. Now, how do you remember which is which? Well, semitendinosus, think of T for top. It is on top. Now, which one is the biceps femoris and which ones are the semitendinosus and semimembranosus? Well, the biceps femoris doesn't have anybody on top of it or underneath it. The other thing is that semimembranosus, think of M for medial. The semimembranosus is on the medial side. The semitendinosus is on top of that. So those 2 of the 3 hamstrings are on the medial side of the posterior surface of the thigh. The biceps femoris is the 3rd hamstring. It's on the lateral side. So here we see them here. Biceps femoris, that's the lateral side. And we have the semitendinosus on top and the semimembranosus underneath on the medial side. Now, looking at the biceps femoris, this will tell us what all the hamstrings do. So remember we said that it would flex the thigh, that the quadriceps flex the thigh and extend the lower leg. Here we see it extend it. The hamstrings do the opposite. Instead of flexing the thigh, they extend it. Instead of extending the lower leg, they flex it. They do just the opposite of what the quads do. Remember back here. Let's go back to the quads real quick. Here. Flex the thigh and extend the lower leg. We go back here, we see oops, extend the thigh and flex the lower leg instead of the opposite. So this will cause the thigh to straighten out at the knee. It will straighten out the leg at the knee, and it will cause, then it will flex backwards. So that just we get the same type of action, but we're doing it in two different ways. You know, extending the thigh and flexing the lower leg by the hamstrings, and flexing the thigh and extending the lower leg by the quads. They are antagonists here. And this, and since they work antagonistically, when the hamstrings relax, the quads are contracted. When the quads are relaxed, the hamstrings are contracted. So, because muscles can only do one thing, they can only contract. They can only contract and then they relax. The only action they have is to contract. And so you're either contracted or you're relaxed. If you're contracted, then if you're contracted, your antagonistic pair is relaxed. So if the quads are contracted, then the hamstrings have to be relaxed. So they have opposite actions. We see the most unusual shaped muscle in the whole body is Sartorius muscle. We have the gracilis, and we have the adductor longus. The Sartorius muscle is shaped like a packing strap. It's a very unusual muscle. It's long and skinny, and it extends from the medial surface of the just about the point of the knee joint, all the way up here to the hip bone. It runs across the front surface of the thigh. Here is the gracilis. The gracilis is found on the medial side from the inguinal region down to the knee, and then the adductor longus runs underneath the sartorius, and this muscle over here is called the adductor magnus. It runs underneath the gracilis. They are all there to stabilize the thigh. Of course, there is the adductor magnus. There's the gracilis on the medial side of the thigh right there, highlighted in green. Its role is for stabilization and flexing them. We're not going to worry about everything it has to do. There's the sartorius. If you ever went to camping and you sat on the floor or on the ground, cross-legged, you were using your sartorius muscle. If you ever sat cross-legged on the floor, you're using your sartorius muscle. It causes the thigh to rotate laterally. When we cross our legs, this is what we're using, is the sartorius muscle. The adductor longus adducts the thigh, brings the thigh in closer to the body, but we just need to identify it. There's the adductor longus. It runs underneath the sartorius. There's the adductor magnus over here, and it runs underneath the gracilis from here to here. Okay, on the posterior surface of the lower leg, as we've seen the posterior surface of the thigh and the anterior surface of the thigh, we've seen the medial surface of the thigh. Now let's take a look at the lower leg. We have this very large muscle here called the gastrocnemius. Lateral head and the medial head of the gastrocnemius. They both insert on the condyles of the femur. The gastrocnemius and lateral head and medial head come together, and their insertion, the origin of the gastrocnemius are the condyles of the femur. More importantly, their insertion is on the calcaneus by way of the Achilles tendon. This is the famous or infamous Achilles tendon that tears. Now, it inserts on the calcaneus, and this the gastrocnemius and the Achilles tendon allows us to plant our flexion, raising the heel when we step. If we tear the Achilles tendon, we can't raise our heel. We can't raise the back of our foot. So we can't walk. That's what happens when you have an Achilles, when someone tears their Achilles tendon. The gastrocnemius, I apologize for the wording getting over in the picture. The gastrocnemius, we call it the calf muscle. It ends on its origin are on the condyles of the femur. It inserts on the calcaneus by way of the Achilles tendon and causes us to plantar flex the foot by raising the heel and flex our lower leg. So here we are. Medial head on the same side as the big toe. Lateral head. There's our soleus tucked underneath there. And there's the Achilles tendon right there. And the gastrocnemius pulls on the calcaneus, bone that sticks out in the back of the foot. Remember, the talus is surrounded on either side by the medial and lateral malleolus from the tibia and the fibula. But here's the calcaneus sticking out in the back. And the Achilles tendon attaches to that. It inserts there and it elevates the heel when we walk. Plantar flexing the foot, plantar flexing, toe down, heel up. That's what the Achilles tendon does for us. And there's dorsiflexion and plantar flexion. Plantar flexion, the heel going up, dorsiflexion, the toes going up. And we do both of these actions when we walk. Heel down, toes down. Heel up, toes up. When the toes go up, the heel goes down. When the toes go down, the heel comes up. And so this combination of plantar flexion and dorsiflexion is how our foot moves when we walk. And it's the Achilles tendon and the gastrocnemius that raises the heel. It is the tibialis anterior that raises the toes. Okay. The torso muscles include the muscles around the face and the head, as well as the torso and around and below the diaphragm. So looking at our head first, we see the muscle that we never get wrong on the test. We have the frontalis, sits on top of the frontal bone, very thin muscle, because you can feel your frontal bone through your skin. But the frontalis is there mostly, primarily, usually for expression. Doesn't really do much for us. Doesn't protect the skull very much, neither does the skin. But the frontalis allows us to show expression. The Urbicularis Oculi. Oculi means eyeball. So the Urbicularis Oculi is a round muscle that surrounds the eyeball. It has nothing to do with vision. It has everything to do with showing expression. We have the Urbicularis oris around the oral opening. Again, it's an expressive muscle. It's a flat, round muscle that shows expression. That's all it does. It has nothing to do with eating. Now, this is a very important muscle. This is the Sternocleidomastoid. This is the muscle that allows us to turn our heads. The zygomaticus muscles, they come right off the zygomatic bone. More expressive type muscles. Now let's look at this in close up. There's the frontalis right there. The Urbicularis oris. I'm sorry, the Urbicularis oculi and the Urbicularis oris there. There's the frontalis right there. You know, it formed from two separate muscles. And you can still see the junction right there. Not like the frontal bone has become one bone. The muscles didn't form that way. But they don't do much. Again, they're pretty much only for expression. The same with the oculi and the oris. You know, they're thin, they're flat, they're round. They don't do much except show expression for us. Here we see one of the chewing muscles. This is the masseter. The masseter, its insertion is on the mandible, and it elevates the mandible and allows us to chew, because the maxilla, the upper jaw, doesn't move. Only the mandible moves up against it. And we crush and grind and rip and tear food between our teeth. The upper teeth don't move. The bottom teeth move when the mandible moves. And it's the masseter. Masseter is one of the chewing muscles that actually pulls those, pulls the mandible up. There's another one we'll see here in a second that we use extensively. There's the zygomatic muscles. Now this is the sternocleidomastoid. It's the one I showed you at the beginning of the discussion. Its origin is on the sternum and the clavicle. Its insertion is on the mastoid process. Its action is to turn the head to the left or to the right, or to bob it up and down, like nodding. For yes, we're turning our head to the left and right for no. So it's a very powerful muscle. It allows our head to rotate in either direction, the sternocleidomastoid. There's some indication in the name where it comes from. Mastoid is its insertion. The sternum and the clavicle show up in the sternocleido. Very large muscle here now. This is one of those with two origins. It originates on both the sternum and the clavicle. It inserts on the mastoid process. When one side contracts, your head turns in that direction. And when the other side contracts, it goes in the opposite direction. If they both contract, your head will rotate back and forth. So we can turn our head to the left or turn our head to the right. We can rotate around the axis, and depending on which muscle, which side contracts, will turn that way. If we both muscles contract at the same time, our heads nod up and down. And then there are some extreme cases too, which don't really happen, but it's just a cool picture. So anyway, we can't do that for real, but it's okay. So we don't rotate. Now, looking at the rest of the muscles of the head, there's the temporalis muscle. Now, the temporalis muscle sits on top of the temporal bone. This is a functional muscle. It's not there for show like the frontalis is. The temporalis muscle is the other big chewing muscle. It works with the masseter to elevate the mandible, to bring it up against the maxilla. There's the masseter right there. Both of those are going to insert on the mandible and raise the mandible so we can chew. So there's the temporalis. It ducks underneath the zygomatic arch and inserts on the mandible. The masseter is attached to the zygomatic bone here, the zygomatic arch, if you will, and inserts on the masseter. Between the two of those, we elevate the mandible. So the masseter is one of the major chewing muscles. When the masseter contracts, it elevates the jaw, the mandible against the maxilla. The temporalis does a similar thing. It attaches to the, it originates from the temporalis, it inserts on the mandible, it elevates the mandible so we can chew. And between the two of these, we have we get our chewing action. Because all we're doing is bringing the mandible up against the maxilla. Like this. See, notice that the maxilla never moves. It doesn't, it's not moving. But the mandible is. The mandible is being drawn up against the maxilla. I don't know what this person's chewing, but no, I'm not going to go there. So anyway, the point is that we draw the mandible up against the maxilla to to crush and grind and rip and tear. Now, moving on down, large muscle above the deltoid is called the trapezius. That's sort of a triangular shaped muscle. It extends very far down on our back. The trapezius allows us to raise our head if we want to look like if we're looking around for something, or elevate our head, or shrugging our shoulders. We use the trapezius for that. This large muscle in the front is the pectoralis major. And yes, if you have a major, you're going to have a minor. And the pectoralis minor is tucked underneath it. And like a lot of muscles, we see that the direction of the muscle fibers changes. The angle of them change from one to another. Like if the pectoralis major tends to go from upper left to lower right, or in this case, upper right to lower left, the pectoralis minor muscles will go in the opposite direction. We see this cross-hatching effect a lot on our muscle fibers. There's our diaphragm. It's a muscle, so we have to include it in our list. It separates the abdominal cavity from the thoracic cavity. Pectoralis major. It allows us to move our arm. It allows us to flex the arm, to rotate the arm. It inserts on the humerus at the greater tubercle when we are climbing a ladder, for example. When we're throwing things, when we're doing push-ups, we are using our pectoralis major. And we can sort of back here. So, yes, let me show you what it's doing here. Notice how it's on the greater tubercle. It inserts on the greater tubercle. It can cause adduction of the arm. Adducting means bringing it close in. It can cause abduction of the arm, pulling the arm out. So, but this is the pectoralis major right here. When you're climbing a ladder, for example, or a rock wall, or a tree, or whatever you're doing, or doing push-ups, you're using your pectoralis major. Okay. Now the trapezius is a very large muscle of the back. This allows us to elevate our scapula and elevate our head. And we see it directly behind our deltoid at the top of the shoulder. We use it to raise our head up, to depress the scapula, to extend the scapula. You shrug your shoulders, for example. You are using your trapezius. When you raise your head up, look around, you're using your trapezius. Here we see examples of that. Right there. Raise or lower the scapula, elevate the head, tilt the head, in one direction or another. Not turn it, but tilt it. Tilt it over, tilt it over. Not, turning it and tilting are two different things. So, directly below the trapezius is the latissimus dorsi. The latissimus dorsi is our hammering muscle. When we do repetitive motion, bringing our arm up over our shoulder and then down, like chopping wood or driving a nail, for example, or swinging a bat at a ball, or playing tennis. These actions are going to use our latissimus dorsi. It extends down, covers most of the lower back. It inserts on the humerus. A very powerful overhand action, throwing a ball, for example, would use the latissimus dorsi. Injuries to the latissimus dorsi often result in lower back pain. Patients absolutely insist that their kidneys hurt and they're holding their lower back. Your kidneys are located up high in here, directly in front of the floating ribs, not down here, where most right above your hips, where most of your patients are going to come in and say, "Oh, I hurt my kidney. Something's wrong. I've got a kidney stone." Well, you might have a kidney stone, but definitely you're holding the wrong place for your kidneys. Okay. And on our model, we can see the latissimus dorsi is a large muscle down here. Here's the trapezius up here, and then the rest of this is the latissimus dorsi right there. Example of the latissimus dorsi. Softball players use that. If you've ever seen fast pitch softball, you know how fast that ball's coming in. This is a powerful muscle. You can see that there's a lot of effort that can go behind that. So the latissimus dorsi is used in that kind of action. Overhand, underhand, overhand with a hammer or chopping wood, underhand with pitching something, for example. Any kind of action like that would involve the latissimus dorsi. Now, moving around the side, we have what's known as the serratus anterior. These muscles stacked up along here. Then, of course, there's the pectoralis major again. And you can just see the hint of the pectoralis minor underneath there, because the major and minor tend to overlap each other. We also have the rectus abdominis. And the rectus abdominis, what we also call the six-pack muscles, they start on the pubis and stop on the xiphoid process. So they run all the way up the abdomen. When the rectus abdominis contracts, it flexes our abdomen. In other words, it pulls the abdomen in. The muscle of the abdomen is contracted. See how, if you look at the animation here, see how when the muscle contracts, the abdominal wall pulls in. You can see how this shrinks. See, and this is the muscle that we contract when we go to pick up something really heavy. The rectus abdominis, we contract that muscle to stabilize the abdomen. And so, and if you ever go to pick up something really heavy, and there are four of you trying to move a piano or something, for whatever reason, you decide to pick it up and not push it. You discover that when you pick it up and you are flexing your abdomen, you are stabilizing your abdomen by contracting this muscle, you have stopped breathing. You hold your breath. Because you don't want your diaphragm moving down in the abdomen and messing, and affecting this. You want to stabilize the abdomen so you can lift that excessive weight. And what you're doing is you're raising the abdominal pressure inside by straining. This is how people get injured when we say that someone strained themselves. They developed a hernia or they hurt themselves by straining. What they're doing is they're compressing this abdomen, holding their breath, raising the inner abdominal pressure to the point that it becomes dangerous. So if you've ever picked up something very heavy, and you're really straining to pick it up and you got a little dizzy in here, that's the result of the rectus abdominis contracting, shrinking the space, raising the pressure inside the abdomen. What happened was that when you compress the rectus abdominis and you stimulate, you raise the pressure inside there, you stimulate a nerve called the vagus nerve. The vagus nerve innervates the heart, and it causes the heart to slow down. And when you slow down the heart rate, you are getting less oxygen going to your cells in your brain. And it's not unusual for someone to stimulate their vagus nerve enough that they get dizzy. They may even black out. It happens, by straining like this. It becomes a real concern when we deal with heart patients. Just consider this. I said we were going to get into more interesting topics. You have a cardiac patient that you're taking care of. The cardiac patient often has to take painkillers because of chest pain. Okay, painkillers, particularly morphine-based painkillers, are notorious for causing constipation. Well, when you have an elderly patient that is constipated, the one thing that they really live for is emptying their bowels. I don't know what it is about older people, but elderly people like to be able to say that they moved their bowels that day, you know, and plus constipation. If a person's constipated, it doesn't feel good anyway. But what will happen is many times your cardiac patients will strain to empty their bowels. The term is straining at the stool. And your cardiac patients strain, they stimulate the vagus nerve, their heart slows down and stops. And they strain themselves into a cardiac arrest and they die while they're sitting on the toilet. And so this is a downside of this. This is why you have to be very careful with your cardiac patients that you're dealing with in the hospital or in home health care, that they don't strain, because they don't want to overstimulate the heart to the point where it stops. You know, because the vagus nerve will stimulate the heart to slow down. And it happens. Anyway, a lot of things go on with the rectus abdominis, not the least of which is again, we refer to it as a six-pack set of muscles. The external obliques are on either side of the rectus abdominis. They, if you want to find out where the rectus abdominis are located, stick your hands in your pocket and point your fingertips towards the midline. That's exactly where the rectus abdominis muscles are located. When they contract, they compress the abdomen from the side. So they work with the rectus abdominis to compress the abdomen and stabilize the abdomen. And here we see the serratus anterior. We see the external intercostal muscles. The intercostal muscles are between the ribs. We have both external and internal. The external, the grain of the muscle runs towards the midline. The internals run opposite. Here we see the rectus abdominis, and here we see the external obliques. Now, underneath the external obliques are the internal obliques running in the opposite direction. So if you want to know where the internals are, go back to with your hands in your pocket. That's pointed towards the midline. That's the direction of the external obliques and location of them. Directly underneath your hands and running in the opposite direction would be the internal obliques. Now, if we flip over our torso model, we can see the internal intercostal muscles. Now, the external intercostals, when they contract, they elevate the ribs. When the internal intercostals contract, they depress the ribs. So when the externals contract, the rib cage rises, the chest cavity gets bigger and air rushes in. When the internals contract, the chest cavity shrinks and the air goes out. There's your internal oblique right there. That's all you can see of it. Now, this muscle that runs all the way across here is the transverse abdominis. It's a sheet of muscle. And this muscle here is the diaphragm. Now, the diaphragm is not this entire muscle here. The diaphragm is just represented by this line, but the diaphragm is shaped like a parachute, separating the abdominal cavity from the thoracic cavity. That's all we see. There are the external intercostals. There are the internal intercostals there. The external intercostals elevate the ribs when they contract. The internal intercostals depress the ribs when they contract. There's our diaphragm tucked up under the ribs like this. The location of the diaphragm can be found by the xiphoid process. And the diaphragm and the intercostals work together to breathe. When the ribs, when the intercostals contract, when the external intercostals contract, the rib cage rises. At the same time, the diaphragm contracts and drops like it does there. When the diaphragm drops and the external intercostals contract, the thoracic cavity enlarges. Air pressure inside the lungs drops and air rushes in. When the internal intercostals contract, the ribs drop, and at the same time, the diaphragm relaxes and rises up. The size of the thoracic cavity shrinks, and air gets pushed out. And that is all of our muscles. So let me get back to a lot less to cover than what we have with bones. And a lot of the stuff that we see here is directly tied into the bone, often sharing the same name as the bone. So I'll go ahead and get you a list of all the muscles and the important actions and insertions and origins for you. I'll get that to you probably today. But that's everything on muscles. Next week we'll go over it again and keep on going. Anybody have any questions? Okay, then I'm going to get us out of here. Oh wait, comment. Okay, thank you. Okay, I will see you in class later this week then.